So, welcome back. Just going to push the chair out of the way, say hello to everybody watching, and we are back live here from Murnau. If somebody's watching from some other part of the world, maybe we are in the south of Germany, south of Munich, close to the mountains, very close to the mountains. Austria, not very far away, not very far to Italy, and of course we're having some bad weather like everybody else or most people here in Germany at the moment. But that's not what we're here about or here to talk about. We want to talk about the brain again. I want to apologize. I kind of messed up 2 weeks ago because we had some things going on at school and they kept changing the timing and the scheduling and everything like that. So I got kind of confused, and in the end I ended up sitting in school instead of being here, which is absolutely fine because I was there for my children, for my daughter, so that's perfectly fine. And I kind of missed out telling everybody who's waiting for a webinar here live on Instagram or on Zoom. So of course we're recording this again, so this is going to be available on Instagram TV, and I'm happy to see that there's quite a few people watching the videos, the recordings. We also record this in a bit better quality with microphone for our YouTube channel, Neurologic Academy TV, and we're going to post that on YouTube after we process the video data. So this is all available. This is episode 13, and we're going to be talking about the skull today, the cranium, because I think there's a few things we need to talk about and some things I need to talk about what's happening in practice, what's happening with patients. So you get an idea of why the cranium is extremely important to be looked at, why it's extremely important to be treated to get better brain function. So that's what we want to have. We want to have better brain function, but we can't have better brain function if we have a dysfunction in the cranium. So I was in osteopathic training, of course, and this, of course, is something that helps me now looking at the skull, but I'm looking at it in a different way. In osteopathy, we kind of looked at the motion of the skull. We said that there, well, if the temporal bone is not moving like it should, then this is a dysfunction and we need to treat that. This, of course, is a very motor way of looking at it, efferent way of looking at it. I'm looking more at the sensory part now, the neurological aspect of, for example, the trigeminal nerve, which is everywhere in the face and in the cranium, in the neurocranium. So, and what I saw over time is that if the cranium has a problem, or if the nerves in the cranium have a problem, and that is mainly the trigeminal nerve, you always, I would want to say that always get a dysfunction in the brain also, and brain dysfunction that might be looked at in some other ways. And I want to talk about this today, what this might look like and what the cause of that could be and why this correlates with each other. So the cranium is extremely important, and everybody who's watching today for the first time, we have a whole bunch of episodes going through all the parts of the nervous system, looking at it from a functional perspective. Functional neurology is what we do here. Functional medicine would be the what you would want to call it. I'm just going to say hello to everybody watching. Thanks for watching. Thanks for tuning in. And of course, everybody who cannot watch the whole thing, we are recording this so you can watch it anytime. And what I want to do today is I want to not go so long. I've been spending like 45 minutes talking lately. I just want to put that down maybe to 25 minutes. So, because we all have a lot of things we want to look at, we all have a lot of things we want to learn. So I need to get that information out faster, of course. Maybe at this time, I want to say that we're hoping to get more out in English in the next year. So 2022 is supposed to be our year of converting all the knowledge we have, all the knowledge we acquired over the past 18 years, to get that into transferred into English. So that is also available. What is available right now already is on our YouTube channel. We have the full seminar number 1, our fundamentals of neurofunctional integration, is available. 18 videos to look at, to watch all the steps, how to treat and integrate. And with video 1, there's the whole manual is available. So if you can download that, it's all for free. You can look at that and you can just see what we're doing, because that's the most important thing. We have to get this information out there because there's still not enough neurology out in medicine. So still a lot of biomechanics, that's fine. If I have a biomechanical problem, I might not fix that through neurology. I have to, of course, look at that. I could have a biochemical problem. Of course, that could be very important, very limiting. If ATP is not available enough, so I will not get a function. So I need information. That's what the brain is doing. I need ATP. I need energy, and then with that I get a function. So this is what we're looking at. We're looking at the neurological part, the information part. So, but the information processing system, the brain, of course, also needs energy, also needs blood supply. And if I have a cranial problem, if I have a problem in my cranium, I could have an altered blood flow to my brain, to my head, which then would alter the function through limitation of energy supply. So here's a patient. This is years ago. Years ago in my practice, a patient came in, elderly lady in her 70s, and she's saying, well, I've been diagnosed with panic attacks, panic disorder, and depression, and but really I don't know why I have that, and they're treating me with antidepressants and medication for psychological disorders, which are not working as they should, which is often the case. And she was not satisfied in the first instance because she said, I don't have any reason to have that. There is no reason for me to have panic attacks or depression because I'm married, I'm happily married, I don't have any worries about money, all my children are alive and well, so there's nothing really to worry about. So she said, it doesn't make any sense. It's not a psychological problem. It's not an emotional problem. So that's that way she came to see me. And of course, when I looked at her and through my osteopathic training, I was looking at all the body parts and also the cranium to see how that is working. And it was very interesting because the whole one side of her cranium was completely well, like we learned in osteopathy, not moving. So it was not moving the way it should move. So we started testing, neurologically testing, sensory testing on the cranium. Of course, the skin, the hair follicles, the touching the skin, different sensory inputs to the nerves in the skin, which is not only trigeminal nerve but also other nerves coming from the cervical spine. So occipital nerves and the nerves around the ear. So we were testing all of that, and of course then we were also functionally testing the bone structures, the sutures. So a lot of testing I'm doing with vibration. So using a tuning fork with 128 hertz is one of the best ways to test mechanical irritation in the nerves. And but also sometimes that is not enough, so I use like a little massage device to really get that cranium shaking to find the neurological dysfunction. So we did that, we integrated all that with a technique I already showed, and I'm going to be showing more of that hopefully next time. I don't have anybody to show anything today. So we tested it, we looked for the dysfunctions in the nerves, and we integrated the dysfunctions in the nerves, and then I looked at the cranium again. The cranium was feeling a lot better. So I don't want to say it was moving a lot better because that's like the osteopathic view, which I don't know if that's what the cranium is really doing, moving, but it felt a lot better, and the patient felt a lot better right away. She felt that she had relief in her head, tension going out, whatever she was feeling there. But the main thing is she came back the next time. She said she doesn't have any panic disorder anymore, and she also does not feel depressed anymore. So how could that be? How could a cranial dysfunction be? And also the question, of course, was why was this happening? And when I was touching the head and when I was examining the head and when we were testing the head functionally, neurofunctionally, of course I was asking her, well, what happened? What happened to your head? And she then, although I asked for trauma, I asked for accidents, she then said, well, I don't know if it matters, but I fell down the stairway and I landed on my head. So that was the story. I said, well, yeah, of course. And when did this happen? Before or after you got your anxiety disorder or your panic attacks and your depression? She said, well, of course that was before. So she fell on her head, she fell down the stairs, she fell on her head, and about a month or two later she started developing those emotional or psychological symptoms. So that's just a symptom. Has nothing to do with a psychological or emotional cause. It's just a dysfunction of the cranium causing a dysfunction in the brain. So that kind of triggered me into looking much deeper into these issues about the nerve supply to the head, the nerve supply to the autonomic nerve supply to the head, the autonomic nerve supply to the blood vessels, and all these things. So that's what we're doing now. We have much more options now than we have years ago, although what I had already did work quite well. Looking at the different neural routes, I want to say, going to the head through the sympathetic nervous system, through the autonomic nervous system of the trigeminal nerve, of the glossopharyngeal nerve, all these things, and test that in a very differentiated way to find out the problem that's going on with the head before thinking too much about the brain itself. So this needs to be taken care of, and of course the blood vessels can be dysfunctional without having a cranial dysfunction. I see that, for example, in whiplash injuries, so the people do not hit their heads anywhere, but they have a whiplash injury causing stress on their neck structures, which also include the blood vessels going through the neck. So that can of course also happen. So then you have to treat the blood vessel, the carotid. You have to treat that because that is also innervated, and not the head. But if the head is if somebody hits the head, then you have to treat the cranium. So I'm not sure which other modality in medicine besides osteopathy really looks at the head. And I'm saying, well, this is so hugely important because it's, first of all, it's coming from the neural crest. So the neurocranium, the back part of the cranium, not the visceral cranium, the neurocranium evolves embryologically from the neural crest. So it's neural tissue. So that should kind of give a hint that it might be important. But then if you look at the innervation, and that's the clue, the innervation of the skull is also the innervation of the blood vessels, and that could be the link to why dysfunction in the nerve in the skull will cause dysfunction in the same nerve in the blood vessels, causing a problem in blood supply. Of course, if somebody comes in and they don't recall any trauma, and you see that the head is not, or the nerves in the skull are not working properly, you can only assume that it's been maybe a trauma they didn't realize because they were a kid or a toddler or something like that. But it could also be that the other way around, a dysfunction inside the head causes a dysfunction outside the head. So, but if you have somebody like that lady who fell down the stairs and had a trauma to her skull, of course, that makes a whole bunch of sense that causes a dysfunction in the neural supply of that part of the head, which then could in turn cause a dysfunction in the vascular supply. So here's something that they do nowadays, just as a similarity. So they're doing an electric stimulation of the ophthalmic nerve after brain trauma or a stroke, to get a better blood flow to brain regions in the front part of the brain. So because they know that part of the ophthalmic nerve is outside on the skin, but another part of the ophthalmic nerve is inside in the dura and in the blood vessels. So, and they can see that with measurements, that if you electrically stimulate the outside branch, you will alter blood flow on the inside branch. So that is proven science. So what we are doing is not proven science. I emphasize that all the time, but I can only see that people are getting better when I treat their skull, when I treat their trigeminal nerve supplying the skull, the sutures, the bone, the dura, all these structures need to be taken care of. So here's another example from my practice. So here's a young guy coming in, 19 years old, I think, and he's in sports. So he comes in after an injury to look at the injury, but also to check up on the whole person, because that's what I usually do. I don't only look at the injury, I look at the whole coordination, balance, all these things. So he comes in and I'm doing neurological testing with him. And we're doing rapid alternating movements. And instead of him being like this as a sports guy, he was like this also on the right side, but even worse on the left side, it was like more like this. Really bad rapid alternating movements. So there is a hint to have a look at the cerebellum. But of course that was not the only place. It also occurred here in his arm. It also was here in his fingers. It also was a little bit in his leg. And fortunately for him, he was playing soccer, or he's playing soccer. So this was not as bad as this. But still, this was also not okay. Also the foot tapping, all the rapid alternating movements on that side were not good. Were really not good, and even on the right side, they were not good. So if it's only here and everything else is fine, of course, it might not be the cerebellum, it might be something else, nerve supply, spinal cord, segmental level, anything like that. But this was on the whole side. So that was really a strong hint towards cerebellar dysfunction on that same side, on the left side. So then I looked at all the body structures, I looked at the breathing, everything, and of course I looked at the skull. And what did I see? I saw a dysfunction, and I'm going to explain by what I mean by seeing. I saw a dysfunction in the left part of the occiput. So palpation, of course, everybody who does osteopathy has a special way of palpating, cranial rhythm, whatever that is. Of course, you can palpate the sutures, and sometimes you feel the sutures, and when you feel the sutures, you feel like maybe it's like a little swollen or something. It just feels different, or the patient might even say it's kind of irritating to go along or to push on the sutures. But this was not a sutural problem, in my view, because it was more a problem of the bone. So that's a special way of examining, and I teach that also, how to examine bone with your fingers. It's more like feeling, more feeling than a touch. So this was just a hint saying, well, this part of the head, this part of the skull, this part of the cranium does not feel right. He could not recall any trauma he has received to this. But of course, if you're in sports, it's quite likely that you get hit in the head at some point. Either it's another head bumping into your head, or it's an elbow, or you fall against the post. He was a soccer player. So anything can happen. You might even not remember it because it might be just happening under a lot of adrenaline, and maybe you just have a little bit of headache for 1 or 2 days, and maybe then it's gone, and then you kind of forget about it. So this could be what happened, but I don't know, because he couldn't remember anything that was significant. So, but this was very obvious to me that there was a dysfunction more in the skull. So how do we differentiate that? Of course, we do a lot of testing, neurologic testing, to see where does the body react. So you can start on the outside with just using air to kind of activate the hair follicles, see if that's a reaction in the skin. Or you can touch the skin very lightly, which will not affect the bone so much, so then you're working with the occipital nerve. And there was no reaction really to that, maybe a little bit with some of the sensory stimulus we used, but there was more reaction coming from the body in terms of sensory motor dysfunction when we went down to the bone level, so activating the bone. So I use a lot of vibration. Sometimes I just use a tuning fork. 128 hertz is what I use. I also have this is like a little massage device. I even use this on the skull. So I just go right to the skull, punch the button so it activates, vibrates the bone, and then go then do my sensory motor testing, or my motor testing. And this was obvious. And what I also like to use my Reflex Hammer. So sometimes I just use a hammer, which you use for tendon reflex testing, and go right to the skull. And there it was also when I did that. The whole side went lame on the left side. So that was the strongest reaction he showed. And of course, we integrated the way we integrated. For those who have not watched me integrate something, and I will show something hopefully next time again with somebody, with a person, maybe my daughter or my son is going to come along, or somebody else. And so what we usually do when we stimulate one part of the sensory system or one part of the nervous system, anywhere peripheral, or even central stimulation. You can also do that through certain functions. So stimulating that, causing a motor dysfunction on that side, meaning that muscle patterns change in an unphysiological way, that will show a wrong reaction, or a distorted reaction to the sensory stimulus. So that should not happen. So we could also test that. When we did that, I showed him that when I went on this side of the skull, activating this part of the trigeminal nerve and other nerves that are more in the back part of the brain, back part of the skull, this changed muscle patterns in his left side. Doing that on the right side didn't change anything on the right side. So that differentiation also showed the patient that there's something wrong on the left side. Okay, so then we integrate that by looking for a stimulus that would eradicate that wrong reaction. So meaning that if his muscle pattern or his movement pattern changes in a pathological way, just by stimulating the skull on that side, maybe an activation of some part of the brain, some part of the nervous system would alter that. And that's what we're looking for, and that's what we then integrate in combination with the pathological stimulus. So we did that. We did, of course, also there was something I said, a little bit on the skin, a few tests going down to the bone, and we looked at also the autonomic supply in terms of the sympathetic nervous system, if there's an activation problem there. I don't remember quite if there was something. But in the end, and that was to the surprise of that young man, when we did that, just working with his skull, not working with any motor function really, he was able to just normally move his hands. He was still a little bit slow in what I consider to be somebody who does sports on a professional level, but that was way better than before. And we did not work with motor systems, we did not work with motor function, we just worked with the sensory system, or not only the sensory system, also the motor system of the skull, because if I work with the sensory system, I probably also work with the motor system within the trigeminal nerve, within the dura, causing a different blood flow, then causing a different function. So that was very obvious, and this happened within 20 minutes. So I tested him in the beginning, we did all the treatment of the head, then we tested him again 20 minutes later, and it had already changed completely. So these are two examples of why it is so important, in my view, to take a proper look at the skull, because there's a huge nerve, the trigeminal nerve, the main nerve innervating outside parts, except for the back part, outside parts of the skull, the skin, innervating dura, innervating vascular tissue, innervating the vessels, the blood vessels, mainly what is called the extrinsic vessel system of the brain, which is the blood vessels on the top of the brain, outside of the brain. And this system also has two functions. So function number one is, of course, blood supply to the outer parts of the brain. Function number two is regulating pressure inside the cranium. But that's very important. The cranium is a very hard structure, so there's not a lot of mobility in the system. So if the pressure inside or outside changes, the adaptation of pressure needs to be taken care of by the vascular system. So the extrinsic vascular system is also for regulation of pressure inside the cranium. So that's what also people have who have cranial dysfunction. They have pressure problems, which causes headaches, which causes migraines. The outside pressure changes. They have weather is going up or down with the outside pressure. They get a headache because the body is not able to adapt the pressure inside the cranium, which then you have to look at the cranium. Of course, you also have to look at the blood vessels. You also have to look at the lymphatic system of the head. Of course, that is also in there. And one big nerve is, of course, the trigeminal nerve. Not only, there's also other systems supplying the vascular system, which is the sympathetic nervous system with the cervical ganglia, and also the glossopharyngeal nerve and the facial nerve through some of the nuclei in the brainstem going also to blood vessels. So hugely important to look at cranial function. So let me talk about another patient I just saw today. So here he is coming in telling me the story that he had a head trauma, and that was not that bad, obviously, so he didn't go to the hospital. He went to sleep and he woke up and his left side was not working anymore, hemiplegic. So of course that he didn't realize, because he was suffering a hemorrhage in the brain, and unfortunately he was only found 2 days later. He survived and brought to the hospital. They opened his skull, they drained the blood out of the skull, and of course then he went to rehab. And now this is 23, 24 years later now, and he is asking me if I could help him. Not only with that issue, but that's of course one of the issues. Looking at him from a neurologic perspective, we did just some Romberg testing. So he was standing there, legs closed, legs together, eyes closed, arms out. See his sway. So he was swaying to the right quite a lot. So you might think of a dysfunction in the utricle on the right side, maybe. So that could be one idea. Also, when he was standing on one leg, and I didn't do legs, eyes closed, one leg testing, he kind of had a tendency going off to the right side. So all the standing, the stabilization was showing a problem going to the right side. So this could be, or most of the times this would be a problem on the right, in the right part of the vestibular system, but it also happens that it's the other side. So they are working together, and you kind of have to figure that out through the testing, which side is really the problem. So that's what we do. We differentiate that. But since he had surgery on that side, he didn't get hit in this part of the head. He got hit on the other side, and the hemorrhage took place in that part of the brain where the brain smashed against the cranium. That's where the hemorrhage took place. So he had an operation scar right there. And they didn't take out a whole big piece of bone and put it back in. They just drilled a hole to release the pressure, and with the scar, of course. But looking at the cranium, looking at it, of course, you see the scar, you see the operation, or the what's left over from the operation, and touching the skull was quite obvious that this part, especially the part with the temporal bone part was quite dysfunctional, I want to say. So it did not feel right. That's just want to leave it that way. So we did not work with any testing of the vestibular system just in the beginning and in the end. So what I mean is that we didn't treat the vestibular system specifically. The first thing we did was we treated the skull. So here we go again, going through to see, is it more coming from the level of the skin? Is it more coming from the level of the bone? Here again, it was more the bony level. It was partly the sutures, so the suture part where you have more nerves than in the other parts, it was reacting, and also the bone was reacting to a different stimulus. So I used different stimulus for the suture and the bone. And we integrated that. In that case also, what we had to look at in his case was all the sympathetic nervous system. So the cervical ganglia, we had to look at those. And especially the top cervical ganglia, which is associated with the dysfunction, autonomic dysfunction in the head, outside, inside, everywhere. So we kind of had to take that into the equation to get the problem out of the way through that neurofunction integration process that we used for treatment. So I did that, and we stood him up again, and he was standing, and he was not swaying off to the right. So this was another example. And why is that so? Because, of course, the vestibular system is inside the temporal bone. Pars petrosa, we say in German. No, it's Latin actually. So that's where the inner ear is sitting. That's where the vestibular system is sitting. And of course, if you have a problem in the autonomic system, in the autonomic nervous system, the sympathetic nervous system, the cervical ganglia, in association to that part, you can imagine, or you can think of it as a dysfunction in blood flow. So this might affect the outside of the head, the skin and all that, but this might also affect the inside of the skull, maybe also the blood flow to the vestibular system. So that was maybe what we did. We don't know, because we can't measure it directly. We can only measure it indirectly through testing, seeing what causes dysfunction in sensory motor patterns, and then in neurological testing before and after, seeing that, okay, here he was swaying off to the right, and after the treatment he was not swaying off to the right anymore. And when he walked, he also said immediately, this feels completely different. This is much more stable, and we did not treat the vestibular system directly by doing vestibular testing. We treated the skull. So of course that makes a lot of sense, but I just want to emphasize that because I see a lot of neurological testing where it's always like the last function. So I'm thinking of it, okay, when I do a vestibular testing, and the vestibular testing is not good, it must be a dysfunction in the vestibular system, which in a way is correct, but I would say no, it was not a dysfunction in the vestibular system. That was a secondary dysfunction. The primary dysfunction was in the cranium and in the autonomic nervous system going to the cranium. So that was my primary dysfunction, causing a secondary dysfunction in the vestibular system. So maybe I'm wrong with that. That could be, because I do not have any measurement that would prove that, but I see it that way quite a lot, and I can differentiate between a problem of the skull and between a problem of the vestibular system, because you have people who have no problem with the skull, but they have a problem with the vestibular system, and you have to approach that in a different way. And you always have to find, of course, the most effective way to get that out of the way, which is, for me, going to the primary problem, which is not always what you can see, but of course you have to look. So I want to encourage everybody who can to look at the skull very closely, because it's made from neural tissue, in the embryological development. It's connected through, especially through the trigeminal nerve, the outside, the skin part, the bony part, the dural part, and the vascular part connects it from the outside to the inside, and also the other way around, so that you can see, and I always see that. I wouldn't say that if I have a patient who has a skull problem, he does not have a neurologic problem that is associated with that part of the skull and that part of the brain that is in or behind or under that skull. So I would say it's always like that. That's what I want to say at this point. So that's why I think it's very important to have a very close look at the outside of the brain and not always jump into the brain saying, oh, I have a brain dysfunction. Well, why do you have a brain dysfunction? Why is that? Did I hit my brain? Of course you can do that. And that's maybe you have to go at that differently. But first thing I hit when I get hit in the head is my skull. So that's what I wanted to talk about. And as I said, yes, a little bit shorter. And I hope I did this correct, although I didn't paint anything. I was always trying to get the thing the other way around so that you guys can read what's on there. And I've missed on that. I'm sorry. My technological understanding is not that bad, but I always have to keep learning. So next time when I draw something, I hope this is all correct. So thanks for watching. I appreciate you coming by to hear me talk. I just want to say hello, and I'm going to be getting out of here. And of course, this is recorded, so you can watch this on Instagram TV. We're going to post this in a second, and I'm happy that there's quite a few people watching that. And we're also recording this on the other camera for our Zoom meeting, and we're also going to be putting that on our YouTube channel. As I said, you can watch that anytime and learn more from us here at the Academy for Functional Neurology. See you. Thanks for watching, and I'll be back in 2 weeks. Bye-bye.